Dear listeners, this video is part 3 of the 4-part series on anatomy and physiology of the heart. For other videos, see Prescribon Medical Education series, Anatomy and Physiology of Heart. Blood flow and oxygen demand of the heart. Coronary blood flow accounts for about 4% of the cardiac output. The heart extracts most of the oxygen, that is about 70%, carried in the coronary circulation. Under resting conditions, the arteriovenous difference for oxygen across the heart being about 110 ml per liter, while that for the whole body is only about 40 ml per liter under resting conditions. Therefore, large increases in myocardial oxygen requirements must be met largely by increases in coronary blood flow, and this may increase 5 or 6-fold during strenuous exercise. The greater part of this flow is to the left ventricle, of which at least 2/3 occurs during diastole because of the throttling effect of systole, that is, contraction, has on myocardial perfusion. Flow is normally evenly distributed throughout the myocardium. Myocardial oxygen requirements and coronary blood flow are finely adjusted and matched with coronary vascular resistance subject to auto-regulation. Rhythmic contraction of heart. The human heart has a special system for rhythmic self-excitation and repetitive contraction approximately 100,000 times each day, or 3 billion times in the average human lifetime. This impressive feat is performed by a system that does the following. 1. Generates electrical impulses to initiate rhythmical contraction of the heart muscle, and 2. Conducts these impulses rapidly through the heart. When the system functions normally, the atria contract about 1/6 of a second ahead of ventricular contraction, which allows filling of the ventricles before the ventricles pump blood through the lungs and peripheral circulation. 3. Another especially important feature of the system is that it allows all portions of the ventricles to contract almost simultaneously, which is essential for the most effective pressure generation in the ventricular chambers. This rhythmical and conductive system of the heart is susceptible to damage by heart disease, especially by ischemia, resulting from inadequate coronary blood flow. The effect is often a bizarre heart rhythm or an abnormal sequence of contraction of the heart chambers, and the pumping effectiveness of the heart can be affected adversely, even to the extent of causing death. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Conductive system of the heart. The sinoatrial node is the pacemaker of the heart. Then there is the atrioventricular node. Thereafter, the AV bundle divides into a right and a left branch, which supplies the right and left ventricles. Now, let us see the conduction system in detail. This figure shows the specialized excitatory and conductive system of the heart that controls cardiac contractions. The figure shows the sinus node, also called sinoatrial SA node, in which the normal rhythmical impulses are generated. The internodal pathways that conduct impulses from the sinus node to the atrioventricular node, AV node. The AV node, in which impulses from the atria are delayed before passing into the ventricles. The AV bundle, which conducts impulses from the atria into the ventricles, and the left and right bundle branches of Purkinje fibers, which conduct the cardiac impulses to all parts of the ventricles. Velocity of signal conduction in cardiac muscle. The velocity of conduction of the excitatory action potential signal along both atrial and ventricular muscle fibers is about zero point 0.3 to zero point 0.5 meters per second, or about 1 by 2/50th of the velocity in very large nerve fibers and about 1/10th the velocity in skeletal muscle fibers. But the velocity of conduction in the specialized heart conductive system in the Purkinje fibers is as high as 4 meters per second in most parts of the system, allowing rapid conduction of the excitatory signal to the different parts of the heart. Refractory period of cardiac muscle. Cardiac muscle, like all excitable tissue, is refractory to re-stimulation during the action potential. The refractory period of the heart is the interval of time during which a normal cardiac impulse cannot re-excite an already excited area of cardiac muscle. The normal refractory period of the ventricle is 0.25 to 0.3 seconds. There is an additional relative refractory period of about 0.05 seconds during which the muscle is more difficult to excite than normal but can be excited by a very strong excitatory signal. The refractory period of atrial muscle is much shorter than that for the ventricles, about 0.15 seconds for the atria compared with 0.25 to 0.3 seconds for the ventricles. Duration of contraction of heart muscle. The duration of contraction of cardiac muscle is mainly a function of the duration of the action potential, about 0.2 seconds in atrial muscle and 0.3 seconds in ventricular muscle. Duration of diastole and systole. The total duration of the cardiac cycle, including systole and diastole, if the heartbeat is 72 beats per minute, the duration of the cardiac cycle is 1 by 72 minutes per beat, that is about 0.0139 minutes per beat or 0.833 seconds per beat. Increasing heart rate decreases duration of cardiac cycle. When heart rate increases, the duration of each cardiac cycle decreases, including the contraction and relaxation phases. At a normal heart rate, 72 beats per minute, systole comprises about 0.4 fraction of the entire cardiac cycle. At 3 times the normal heart rate, systole is about 0.65 fraction of the entire cardiac cycle. This means that the heart beating very rapidly does not remain relaxed long enough to allow complete filling of the cardiac chambers before the next contraction. The atria function as primer pumps for the ventricles. Blood normally flows continually from the great veins into the atria. About 80% of the blood flows directly through the atria into the ventricles, even before the atria contract. Then, atrial contraction usually causes an additional 20% of filling of the ventricles. Therefore, the atria function as primer pumps that increase the ventricular pumping effectiveness as much as 20%. However, the heart can continue to operate under most conditions even without this extra 20% effectiveness, because it normally has the capability of pumping 300% to 400% more blood than is required by the resting body. Therefore, when the atria fail to function, the difference is unlikely to be noticed unless a person exercises. Then, Symptoms of heart failure occasionally develop, especially shortness of breath. Function of the ventricles as pumps. The ventricles fill with blood during diastole. During ventricular systole, large amounts of blood accumulate in the right and left atria because of the closed atrioventricular valves. Therefore, as soon as systole, that is contraction, is over and the ventricular pressure fall again to their low diastolic values, the moderately increased pressures that have developed in the atria during ventricular systole immediately push the AV valves open and allow blood to flow rapidly into the ventricles. This period is called the period of rapid filling of the ventricles. In a healthy heart, the period of rapid filling lasts for about the first third of diastole, that is the relaxed period of cardiac muscle. During the middle third of diastole, only a small amount of blood normally flows into the ventricles. This is blood that continues to empty into the atria from the veins and passes through the atria directly into the ventricles. During the last third of diastole, the atria contract and give an additional thrust to the inflow of blood into the ventricles. This mechanism accounts for about 20% of the filling of the ventricles during each heart cycle. The ventricles stiffen with aging or diseases that cause cardiac fibrosis, such as high blood pressure or diabetes mellitus. This causes less blood to fill the ventricles in the early portion of diastole and requires more volume or more filling from the later atrial contraction to maintain adequate cardiac output. Outflow of blood from the ventricles during systole. Period of isovolumic or isometric contraction. Immediately after ventricular contraction begins, the ventricular pressure rises abruptly, causing the AV valves to close. Then, an additional 0.02 to 0.03 second is required for the ventricle to build up sufficient pressure to push the semilunar, that is aortic and pulmonary valves open against the pressures in the aorta and pulmonary artery. Therefore, during this period, contraction is occurring in the ventricles, but no emptying occurs. This period is called the period of isovolumic or isometric contraction, meaning that cardiac muscle tension is increasing, but little or no shortening of the muscle fibers is occurring. Period of ejection. When the left ventricular pressure rises slightly above 80 millimeters and the right ventricular pressure rises slightly above 8 millimeters, the ventricular pressures push the semilunar valves, aortic and pulmonary valves open. Immediately, blood is ejected out of the ventricles into the aorta and pulmonary artery. Approximately 60% of the blood in the ventricles at the end of diastole is ejected during systole. About 70% of this portion flows out during the first third of the ejection period, with the remaining 30% emptying during the next two-thirds. Therefore, the first third is called the period of rapid ejection and the last two-thirds is called the period of slow ejection. Period of isovolumic, that is isometric relaxation. At the end of systole, ventricular relaxation begins suddenly, allowing both the right and left intraventricular pressures to decrease rapidly. The elevated pressures in the distended large arteries that have just been filled with blood from the contracted ventricles immediately push blood back toward the ventricles, which snaps the aortic and pulmonary valves closed. For another 0.03 to 0.06 second, the ventricular muscles continue to relax even though the ventricular volume does not change, giving rise to the period of isovolumic or isometric relaxation. During this period, the intraventricular pressures rapidly decrease back to their low diastolic values. Then the AV valves open to begin a new cycle of ventricular pumping. End diastolic volume, end systolic volume, and stroke volume output. During diastole, normal filling of the ventricles increases the volume of each ventricle to about 110 to 120 ml. This volume is called the end diastolic volume. Then, as the ventricles empty during systole, the volume decreases by about 70 ml, which is called the stroke volume output. The remaining volume in each ventricle is about 40 to 50 ml and is called the end systolic volume. The fraction of the end diastolic volume that is ejected is called the ejection fraction, usually equal to about 0.6 or 60%. The ejection fraction percentage is often used clinically to assess cardiac, that is systolic pumping capability. When the heart contracts strongly, the end diastolic volume may decrease to as little as 10 to 20 ml. Conversely, when large amounts of blood flow into the ventricles during diastole, the ventricular end systolic volumes can become as much as 150 to 180 ml in the healthy heart. By both increasing the end diastolic volume and decreasing the end systolic volume, the stroke volume output can be increased to more than double that which is normal. This figure shows the structure of the heart. Arrows show the flow of blood direction. Between the right atrium and right ventricle is the tricuspid valve. Between the right ventricle and pulmonary artery is the pulmonary valve. Between the left atrium and left ventricle is the mitral valve. Between the left ventricle and aorta is the aortic valve. All these valves allow blood flow only in a forward direction. Backward flow not allowed. The AV valves, that is the atrioventricular valves, the tricuspid and mitral valves, prevent backflow of blood from the ventricles to the atria during systole. And the semilunar valves, that is the aortic and pulmonary artery valves, prevent backflow from the aorta and pulmonary arteries into the ventricles during diastole. These valves, shown in figure, close and open passively. That is, they close when a backward pressure gradient pushes blood backward, and they open when a forward pressure gradient forces blood in the forward direction. Passively opening one-way valves. For anatomical reasons, the thin AV valves require almost no backflow to cause closure, whereas the much heavier semilunar valves require rather rapid backflow for a few milliseconds. This figure shows the structure of the heart. Papillary muscles attach to the veins of the AV valves by the chordae tendineae. The upper figure for the mitral valve shows the cusps of the mitral valve attached to the chordae tendineae, which are themselves attached to the papillary muscles, which are anchored to the heart walls. Please refer to the earlier two figures for the structure of the AV valves. These figures show papillary muscles that attach to the veins of the AV valves by the chordae tendineae. The papillary muscles contract when the ventricular valves contract, but contrary to what might be expected, they do not help the valves to close. Instead, they pull the veins of the valves inward toward the ventricles to prevent their bulging too far backward toward the atria during ventricular contraction. If a chordae tendineae becomes ruptured or if one of the papillary muscles become paralyzed due to low blood flow from a myocardial infarction, the valve bulges far backward during ventricular contraction, sometimes so far that it leaks severely and results in severe or even lethal cardiac incapacity. Dear listeners, this brings us to the end of part 3 of the 4-part series on anatomy and physiology of the heart. For the rest of the videos, see Prescribon Medical Education series on anatomy and physiology of the heart.